Good afternoon, everybody. Welcome to this meeting of the Leicestershire Health and Wellbeing Board. For anyone that doesn't know me, I'm Michael Squires, Cabinet Lead Member for Health and Public Health at Leicestershire County Council and Chair of this board. This meeting is being broadcast live via YouTube and it will be archived so you can view it online afterwards. Please turn your microphone on when speaking and most importantly, turn it off when you've finished. Apologies for the meeting. We've received apologies from Sharon Cook, and in her place, we welcome to the board for this meeting, Nikki Collins. Welcome, Nikki, from the Children and Families Department. Councillor Cheryl Cashmore is she?
No, she's not.
No, okay, no.
Councillor, apologies.
Okay, fine. All right. Yep. So Councillor Cheryl Cashmore has also given apologies, as well as Carl Abbott and Siobhan Peters. Oh, right. Okay. Yep. Okay. And we've got a substitution of Tracy for John Wilson as well. So item 1 is minutes. So I propose that the minutes of the meeting held on the 4th of December 2025 are taken as read, confirmed and signed. Do I have a seconder? Yeah, everyone agree? Thank you. Urgent items. There are no urgent items. Declarations of interest. I have a standing interest in all substantive agenda items due to my employment with LPT. Do any other members wish to make a disclosure? Yes. Okay. Oh, yep, didn't see you there.
I think it's my usual one to say that my son works in this building sometimes, an employer, NHS England. He works all the time, but he's sometimes in this building.
Thank you very much. So moving on to item 4, that's the chair's position statement. Copies have been emailed to you and a version is also published on the council's website. As is standard practice, I won't be reading it all out because it's rather lengthy, but the salient points are there. Adult social care services continue to face high demand across all cohorts with increasing complexity of presentations for all elements of service delivery, including formal Mental Health Act assessments and services for young adults with a disability. Recruitment and retention continue to remain a challenge for many adult social care providers, but it is mitigated in part by the council's Inspired to Care team. It popped up. Mitigated in part by the council's Inspired to Care team, and international workers carrying out social care work through the sponsorship schemes supported by a regional team. Chair's engagement. So over the last, since the previous Health and Wellbeing Board meeting in December, I've been out meeting various constituents on casework related matters. Obviously, we don't disclose that at this kind of venue, but that's a regular occurrence. On top of that, you may have seen an item in Leicestershire Matters regarding mental health in farming. I've appeared in a video for the Men's Mental Health Conference, and there is a video, I don't think it's out yet, but I've recently done one on anti-vaping, and it's actually my story about why I quit vaping, which was inspired by some school children, which is a good story. Delivery of messaging over the Christmas period, highlighting the adverse effects of secondhand smoke. So item 5, thank you, is the election of a vice chair. We haven't appointed a vice chair for this year because we'll wait and see what was going to happen with the ICB restructures. We now have a better idea of the board membership, so it's time to elect a vice chair. Are there any nominations for vice chair?
Yes. I'd like to nominate Matt Gaunt from the ICB as vice chair. I think it's in line with the purpose of the Health and Wellbeing Board, which is a partnership and collaboration between social services, voluntary sector, Health Watch, etc., in terms of delivering the outcomes for the population, health outcomes that are required. And I think it would be really indicative of that ongoing relationship and the ongoing commissioning intent from both Health Watch and social care and the ICB. Thank you.
Okay, do we have a seconder for that? Yes, okay. And are we all in agreement? Yep. Okay.
And I just added a caveat that he's appointed for 2 years to save us to having to do it again in a few months' time.
Okay, yeah.
Is that all right? Thank you.
Well done, Mr. Gordon.
Yeah, thank you very much. Very happy to
Mr.
be-
Vice Chair, actually.
Thank you very much.
Okay, so item 6 is the Joint Local Health and Wellbeing Strategy Best Start for Life update, which can be found on pages 13 to 36. This report provides an update on progress in relation to the Best Start for Life priority of the Joint Local Health and Wellbeing Strategy and seeks approval for proposed changes to the current relationship between the Children and Families Partnership and the Health and Wellbeing Board. The report is going to be presented by Mala Razak, Children and Families Partnership Manager, and Sean Gill, Public Health Consultant.
Thank you, Chair. The Best Start for Life strategic priority is split into 3 priority areas, and each of those priority areas includes a set of commitments. Those 3 priority areas are the first 1001 critical days, school readiness, and preparing for life. The Children and Families Partnership is the operational delivery group that oversees the Best Start for Life priority and the work that's being delivered around that. And this report provides an update on progress since the last report came to Health and Wellbeing Board. I'm working on the assumption that people will have read the content of the report, so what I'll do is just pick out a couple of key highlights from each of the priority areas, and then I'll pass on to Sean. So looking first at priority 1, which is around the first 1001 critical days. This is a really key area for partners, as the first 1001 critical days are recognised as a really important developmental stage in children's early learning and development. So a range of activities and work has been done around this and continues to raise awareness around the importance of the first 1001 critical days, including skilling up the children's workforce across the range of partners. So work is undertaken through children family services, midwifery and health visiting officers to deliver workshops to newly qualified social workers and midwifery students to make sure that they're really aware of this area of development and can feed that through into their practice. As well as that, some other activity that's been carried on is the second Baby Fortnight and Best Start for Life campaign. Face-to-face sessions and online sessions, as well as social media campaigns, have been undertaken on a range of topics relating to 1001 critical days, and there was a lot of really good engagement with all of those activities. Another of the commitments in this area is around empowering families to access the most appropriate health and wellbeing services. Family hubs remain a really important part of that work, and family hubs are Department for Education funded piece of work that fit in with the government's Best Start in Life strategy. Family hubs remain a really important part of delivering multi-agency single point of access for families with health, education and social care staff all co-located and offering services and in easy access for families to receive joint up services. The second priority is around school readiness, and one of the key areas here is about narrowing the development gap affecting children who are at the greatest disadvantage. So a range of work is going on, looking at targeting families in areas of disadvantage across the county and looking at ways of sharing key messages. So the Early Years Inclusion and Childcare Service from the council have been partnering with local libraries to deliver book start packs to areas of disadvantage, including using buses to go out to our more rural areas. And they're able to model effective book story sharing strategies and provide lots of tips. And this helps. This is also linked in with the early years festivals hosted in libraries, and also supporting families to join the library and engage with early learning activities. In relation to the commitment around supporting families to get off to a good developmental start and accessing support for their early development of speech and language and communication, Leicestershire's maternity and early years multi-agency partnership have identified through our local foundation profile scores that there are aspects of speech, language and communication skills that still remain lower than national averages for children across the county. And children, we know that children with good communication skills are more likely to be school ready and to start their school lives at that stage where they're able to engage in education more effectively. So a new tool, roadmap, has been created to help parents understand the importance of talking to their children from birth. It's an interactive tool that's online. Parents are able to click on different icons and hear in the voices of children the kinds of things that they can be doing with that child from birth through to the age of 5 that would help encourage their speech and language and development. And there are also a number of parent-facing initiatives around awareness raising, so including to encourage families to engage in preschool activities, including postcards being distributed by birth registrars, promotional videos and postcards that are sent to parents prior to them starting to school, encouraging them to take their children to preschool education. And then in relation to the final priority, the Families First Partnership is the name given to the National Programme of Reform for Children's Social Care, and working with partners, police, including police, health and education, there's work underway to respond to the national guidance and build on existing strengths and ensure that we have the services and processes in place that meet the needs of Leicestershire's families. It's building on strength-based and trauma-informed approaches and will help to ensure, wherever possible, that preventative approaches will ensure that children are supported to remain safe and to thrive within their families. So those are some of the key highlights from the work that's been undertaken. And I'll pass over to Sean about the plans ahead.
Thank you very much, Marla. So firstly, thank you for having me here today. My first time at Health and Wellbeing Board, so thank you. And thank you to Marla for presenting the great work that's happened over the last year. I just wanted to then briefly present a look ahead and a proposal to how we work in the coming year, delivering that Best Start for Life chapter. So as Marla outlined, to date, the work has been overseen by the Operational Delivery Group of the Health and Wellbeing Board, known as the Children and Families Partnership. That partnership, as well as working towards the Best Start for Life chapter, also works towards the broader Children and Families Partnership plan. And that covers a range of things that aren't necessarily directly related to health, but still have important partnership working necessary. The refresh of the joint local health and wellbeing strategy that's taken place over the last months has led to the Best Start for Life chapter having a much greater focus on health specifically than it did before, which has led us to then consider whether the Children and Families Partnership is still the right group to be the operational delivery group for the Health and Wellbeing Board. because there is now a greater distinction between the direct health-related priorities of the joint local health wellbeing strategy and those wider elements of the wider Children and Families Partnership Plan. So we're presenting today a proposal that a new group is formed to act as the operational delivery group for the Best Start for Life chapter, which would then be co-chaired by someone from the local authority and someone from the Integrated Care Board. The Children and Families Partnership would then sit separately to the Health and Wellbeing Board and focus on delivering that wider Children and Families Partnership Plan. This would mean that membership of both groups can then be better tailored to the respective priorities and agendas that they work towards, helping to further strengthen the partner engagement that those groups have, and also allow greater focus on their specific deliverables rather than trying to do everything across the board in one forum. We also current form, under the current structure, reporting on progress for the Best Start for Life chapter currently goes largely from Priority 5 subgroup of the Children and Families Partnership through to the main Children and Families Partnership and then up to Health and Wellbeing Board. Under this proposal, updates would be able to just come directly to this board, therefore meaning there's a greater direct line of sight between where the work is and the board. So if approved by the board, we will then undertake work to ensure that there's proper alignment of the delivery plans of those two groups and make sure there's clear lines of understanding of roles and responsibilities as well. So that is us, and we would therefore just like to recommend to the board noting the update and the progress and successes of the last year, and recommend that the board approve the proposed changes for the operational delivery group structure. I'm happy to take any questions. Thank you.
Thanks very much. It sounds very much like common sense, really, doesn't it? Is there any questions or comments from anybody on the board? Yes, Jean Knight, and then yourself. Mr. Gorn.
I'm sure you would have considered this, but obviously the wider determinants of health are much greater than just the provision of healthcare. So in relation to splitting that out, how will then the partnership continue to ensure that all plans are made in partnership and looking at a much broader perspective than just the health element?
Absolutely. There's a huge amount of, although they're different, there's a huge amount of overlap, as you say. So we would make sure that senior members of both groups are still members on the other to ensure there's crossover. And we have suggested that we look at arrangements such as, does a update report annually just go from one to the other? There'll be elements, for example, as Marla spoke about, the Best Start in Life school readiness priority that is a national priority at the moment. Great work is currently happening on that, and that focuses on early years and education, which influences health again, but isn't necessarily directly focused on health. That would likely carry on with the Children and Families Partnership, but we would be linked in with that rather than us delivering it ourselves and disrupting the good work that's already happening. I hope that makes some sense.
Thanks, colleagues, for the update. It's such an important phase in every person's life, and a healthy start supports long-term good health outcomes, obviously. My question is really about the nature of the role within the ICB and whether you've already had some discussions internally, and just check there's no sort of overlap with an existing group. I'm really supportive of joint working. I think that's the way we have to go, and we do lots of it. I just wondered if you could just address those 2 points, please.
Absolutely. We've been working jointly with Helen Mather, who, forgive me, I'm now blanking on her job role, but lead for children and young people within the ICB. So we've been working with Helen to work up these proposals to make sure that it works with the ICB as well, and as you say, doesn't create unnecessary overlap or duplication there.
Alan, come on, did you have a question? Ms. Barber, okay. Go ahead.
Thanks. Fiona Barber from Healthwatch, Leicester and Leicestershire. Hi. There sounds to be some really excellent work contained in this, and it's worth recognising this from the board. One of the things I think that people do get concerned about is what are the actual outcomes from this? Are there some real success stories here where you're impacting on children's health, and can you clearly demonstrate that the work you're doing, the outcomes are actually what we want to see as a board that are contributing? Because it sounds really good, but it's actually knowing that impact, those services are having the right impact for the right people. And the other thing that Healthwatch hears quite a bit on is that people find it really difficult to access services. And so anything going forward that reduces that difficulty and makes them much more open to and inclusive to people sounds particularly good. For example, the family hubs are really good in theory, but I guess we've only just got the money at the back end of last year. So it'd be interesting to know how fast and how broadly those are going to be stood up across the county so that people can actually access them easily to meet their particular needs. And the other thing, I didn't see anything around, there's lots of mention around schooling early years, but I didn't see a line which says the children that are being homeschooled and the access to support and facilities that they might have. And that seems to be, from what we're hearing, that seems to be an increasing trend, people taking kids out of school to homeschool.
Thank you very much. I'm really sorry, I've forgotten the first point that you made.
The first point is about all the good work.
Yes.
Are the outcomes? Can you actually articulate the outcomes that are being achieved so that children are better, healthier, more engaged? Can you actually identify that?
Yeah, thank you. Sorry. I think that work will really come well with, I think, the next agenda item that's coming up with regards to the delivery plans for the health and wellbeing strategy, and then dashboards that are being developed as well. So looking at the Best Start for Life chapter, we'll be looking at developing a dashboard of indicators that link to the commitments and the success measures that we've identified in the joint local health wellbeing strategy. And then that will provide us with that mechanism to really show what is the direction of travel on these key indicators, and not only are we red or green, but what is the direction of travel there. And hopefully that piece of work will really help to sort of link up that, what are we doing and what does it actually mean for children, families in our county. So I think that works in train, and hopefully that will help. And a really good point about the home educated children, and I'll take away and have a further look into the offers out there.
I was just thinking about the family hubs, how quickly and what sort of spread. Thanks.
We're currently in the process, led by Children and Families Department, of developing our Best Start in Life local plan. So as part of this good levels of development and Best Start in Life project strategy set out by government, each local authority needs to develop a Best Start in Life local plan, and then family hubs will be integral towards that plan. So that is in development. It would be colleagues in Children and Family Department who then know that detail, because they're the ones who run those family hubs, but it will then be represented in that work coming out next month, I believe that is. So hopefully more detail then.
Hi, Sean Mulder. I think it does make sense, because sitting on the board and with all the work going on about the refresh, even I was trying to get my head around how does this naturally fit, and no one's fault. It just seemed very disjointed. And I think this will actually give that clarity that's needed about what sits where and who does what and how it works. I suppose my question really is, and it might also just be can we have pick this up outside of this meeting, is under the proposed changes and about potentially who you're seeing being on the place-based group, although I know it says not limited to, voluntary sector doesn't exist in that list. So I think it was just basically saying, can we have a chat with you? Because I think, this is a really good opportunity as you're sort of refreshing things and looking at things like this, to look about who is actually out there from the voluntary sector that could actually give you some like fresh insights or can actually help you with things that you're trying to do. And as I've said previously at this meeting, we've just launched at VOW our chief execs for the voluntary sector network. We've got 70 chief execs across Leicester and Leicestershire coming together on a regular basis, some who are children and young people's organisations. And again, it will be good to try and get them linked in with you as well. So also maybe you've got a bit of a voluntary sector sounding board as well for the future.
No, that's excellent. Really welcome that. And apologies that missed you off the list, but I will reach out to you separately. Thank you.
Yeah, just to say, yeah, I found that really useful report, and there was a few things in there that I think at UHL we could start to signpost to. So in maternity, so like the roadmap tool you mentioned, the Active Mums Club thing sounds interesting as well. So if we're not already, I think I'll probably suggest that we do that more, just to join it up a bit more. Thank you.
Sorry, I was just wondering if we could have I can make a bit of a counter proposal for you to think about. It's whether or not we can review that change in organisational structure. Sorry, I'm Jean Knight, the Managing Director for the Leicestershire Partnership Trust, in maybe a year or 6 months' time, just to see how it's working. I really do have genuine concern that by splitting it, we're going to lose some of that partnership and that collaboration. And I think that would be at detriment to all the amazing work that you've done and you've shared today in terms of those achievements. So it's just a proposal, really. Thank you.
Sort of similar point to Jean's, but different. I was thinking about what can we do to make certain that we, as a health and wellbeing board, don't lose sight of everything else, because the other way around, I think it is a good proposal. It kind of makes sense for me that groups focus on what they need to and don't duplicate. But there is a point about, like, for instance, I wouldn't want to lose oversight, not from a controlling point of view, almost from a celebratory point of view, of all the work that Children Families Partnership is doing, because that is so crucial to overall child health. So in my mind, I was thinking, Marla, there's always open door to come and present anything you want to, but we might want to think about how do we do stuff at a health and wellbeing board development session. So I think as part of the review, I'd almost say, let's give a bit of thought to how do we make certain there's continuing good relationships. I know there would be, not just in terms of reporting across the two groups, but to us and to the partnership, because it also there is something there, particularly in relation to the good level of development target, which I think is an LCC target rather in Leicestershire, but clearly there's quite a lot for health visitors in the GLD target, but equally it's the children and families and it's the children's partnership bit. So I think there is space to think about how do we make certain that we play our part in keeping things together as well as asking for a review. So, yeah.
Okay, any other questions or comments from anybody? No, okay. Well, I'd like to say thank you very much for coming. Didn't know it was your first time. It can be a little bit nerve-wracking. It was my first time. So I've added a slight amendment, Mrs. Knight, that this is to be reviewed in a year. Would that be agreeable to you? Okay. So in that case, then I will propose that the board notes the progress being made in relation to delivering against the best start for life priority, notes the progress being made in relation to delivering against the cross-cutting priorities, approves the proposed changes to the operational delivery group of the Health and Wellbeing Board overseeing the Best Start for Life strategic priority, and reviews that in a year. Can I have a seconder, please? Thank you. Are we all in favour? Okay. Motion carried. Okay, on to item 7. Item 7 is the Joint Local Health and Wellbeing Strategy Easy Read and Delivery Plan, which is on pages 37 to 74. This report seeks approval to amend the wording of a commitment in the Joint Local Health and Wellbeing Strategy and approval of the Easy Read document, as well as presenting the delivery plan. This report will be introduced by Abby Vaughan, Health and Wellbeing Board Manager.
Thank you, Chair, and good afternoon, everybody. I'm just going to share some slides with you to take you through this report. Just bear with me. Appeared on screen, lovely. So my name's Abby Vaughan, I'm the Health and Wellbeing Board Manager. Thank you for having me today to present the report. And I am joined by Sean McGill from the Children and Family Partnership, Lisa Carter and Kerry Core from the Integration Executive that will join me in presenting their delivery plans later on in the presentation. So as mentioned, the purpose of this report is to seek approval of an amendment to the original strategy that was presented back in December 2024, to present the easy read version and seek approval of that document as well, and note the first iteration of the delivery plan. It's been in development for a couple of months, so it's quite early on in its design. So just to note, this report can be found on page 37 onwards. So the first part of this presentation really is to seek approval of a small amendment to the revised strategy. So we've proposed that there's a rewording of the healthy homes commitment within the staying healthy, safe and well section of the strategy. It currently says we will work together to make sure homes are affordable, safe, warm and of suitable quality and type to support lifelong wellbeing. So the proposal today is to remove the term affordable from that commitment, as when we were reviewing the Easy Read documents, it became prevalent, obvious that we cannot directly influence the house market prices. And if the wording does remain in the commitment, it could make potentially residents expect action for us to lower rents or house prices. So the intent within this strategy is to ensure housing supports health and wellbeing, really addressing housing as a wider determinant of health, warm homes, quality and safety, etc. So the updated wording would be more accurately reflect areas within the partnership sphere of influence. So I don't know if you've got anything to add, Mike, to that, but that is the general proposal for the
Just to agree with you, Abby. I mean, apologies to the board because we probably should have picked this up when we were doing it before we got to Easy Read, but Easy Read did give a final opportunity to have a look at commitments. And yeah, I mean, there probably are things that we can do as organisations which have some impact on affordability, notably planning applications and social housing or affordable housing might put them in. But it just felt to, as a health and wellbeing board, to commit to making housing affordable. Don't mind us stretching ourselves, but I can't see that we can affect the housing market that much, despite my personal experience of normally quite successfully managing to buy houses and then find they fall in value, but that's another matter entirely.
So we'll take the decision at the end of the paper, but that is the proposal for that part of the report. There are 3 sections, so I will move swiftly on to the second section if everyone's happy with that. Sure, that's there. So the second part of this report is to seek approval of the Easy Read version of this revised strategy, which you can review in your packs on pages 41 to 61. An Easy Read version of the strategy has been developed, recognising the importance of making the document and its contents more accessible and easier to understand for a wider audience. Excerpts from this document can be reviewed on the next couple of slides. And just to inform you, the changes of the document reflect the new commitments and within the revised strategy, and collectively we agreed to utilise illustrations as opposed to images, because we had a wider selection to choose from and we felt that they better describes the statements. This document has been produced by a company called Easy Read Online and co-designed by partners across the partnership. And this process has been led by the Joint Local Health and Wellbeing Strategy Steering Group. So as you can see on the screen, there's a couple of slides here to demonstrate what that looks like. The first one really describes an introduction to the pack itself for the Easy Read users. And then this section here just shows excerpts from the Best Start for Life, Staying Healthy, Safe and Well, etc., which is the life course priority. So the ask of board is to approve this document. We'll take it as read. I'll just move on to the final slide. So the final part of this report is to present the high-level delivery plan that underpins the revised strategy. So the plans can be reviewed in pages 63 to 73 in your pack. The plans in the pack compared to the slides are in a little bit more detail. We show the commitment within the strategy, the associated high-level action aligned to that commitment. We've highlighted some links to other strategic plans across the partnership. They're not exhaustive, but we've made a start on trying to make that strategic alignment there. We've included what success should look like, and that's been taken from the strategy itself, and also included the dashboard indicators that will be used to measure success from a qualitative perspective. So developing the plans, each operational delivery group, my colleagues here, have been responsible for collaboratively developing the deliverables, the actions within the plan. This has included making sure that they're aligned to the commitments and identifying those links to other strategies. So this process is iterative, and the plan represents the very start of this work. Like I say, it's only 2 months old at the moment. Going forward, this delivery plan will be attached to our annual reports and updates to board, as we've seen from Sean for the Best Start for Life today. And following the revised strategy, the development of this delivery plan, we will align it with the organisations' strategies going forward. So as part of our comms and engagement activity, we'll be working with our partner organisations, going to their corporate steering groups, executive groups, to ensure that that alignment and embedding of this strategy occurs. There's also development of the neighbourhood plans. That's in development as part of neighbourhood models of care, and we intend for that work to be as an addendum to this as well. Neighbourhood models is still very much in development, and we will provide updates as that work develops. Next. So this delivery plan is the first iteration, as I've mentioned. The actions that we're going to describe today are at varying levels of detail. Some are quite new actions, so they're quite early on, and some are quite mature, so they're further down the line in their development. There are some gaps as well, so we will highlight what those gaps are when we present. Further actions will be developed as we progress with the delivery plan, and it's very much a live document and a flexible document as well. So my colleagues are here today just to introduce their delivery plans in a little bit more detail. So firstly, I'd like to hand over to Sean, who's going to describe the Best Start for Life delivery plan as it stands at the moment.
Very much, Abby. So the first section of 3 within the Best Start for Life chapter is relates to the first 1,001 critical days. So in this, as Abby said, some elements such as A3 are still in development, and as we pull together the group and are able to start having conversations with the wider group, we will build on these and provide additional detail. Examples of what will be underpinning these actions are, for example, with A1, working to help families feel confident in managing minor health issues, and how to reduce A&E attendances where they're not necessary. Work that's happening there, I think, as was highlighted in the update report, we've got some family hub workers in GP practices at the moment, doing a pilot where they're in attendance and they're able to then support families to understand, are they able to meet their needs in a way that doesn't need health necessarily, but can go through a different route via family hubs. And we're liaising carefully with the city, who are undertaking similar work where they have family hub workers stationed at the hospital A&E department to again understand, are some of these families coming to A&E attending for issues which actually would be better met via alternative routes. So that's an example for the first 1,001 critical days. Next slide, please. Thank you. The next stage is around school readiness, and again, as touched on, one of the key elements here will be around achieving the best start in life good levels of development that we're required to meet. So we have a target in Leicestershire of 78.6% of children, I believe it is, achieving good levels of development by reception. So this will be work that we undertake between public health, the Children and Families Department, and others to look at how we can support that. Elements right before school, even from as early as effective tummy time, to make sure that babies are able to develop that core strength so that they're then able to sit upright and can then develop those fine motor skills are really important. So looking right back at how do our health visitors work and commission services work there? Are our other services promoting sensory opportunities to help with that development for children so that they are able to go to school ready to learn? So that would be a really exciting, interesting area of work. Slide. Thank you. And then lastly, but certainly not least, the third section is around preparing for life. And so looking at our older children and young people. And in here, we've got some actions where we will, again, further develop the detail, but this particularly focuses on vaccinations and increasing immunisation rates, and other elements such as how we can reduce substance use and improve sexual health screening. So that's me. Thank you very much.
Very much, Sean. I'm going to take you now through this Staying Healthy, Safe and Well Life Course priority. On the screen, you'll see D1, which is health and equity in all policies. This is quite a mature commitment. A lot of work has already progressed over the past years within this space. The main aim this year is to increase that awareness and use health impact assessments across Health and Wellbeing Board member organisations, including the provision of training for our partners and sharing that learning as well. D2 is healthy placemaking. This has been a key focus for the Staying Healthy Partnership. And over the past year, since it was agreed as a priority at a development session that took place in 2024, a lot of work has progressed in this space, but the actions really would be around strengthening routine health and wellbeing considerations in planning policy through greater use of, again, the health impact assessments and creating places that support health and wellbeing. So an excellent placemaking session has took place recently with our partners, trying to describe what good looks like for Leicestershire in this space, and the feedback has been really superb from those sessions. So we're looking forward to providing a more detailed update to Health and Wellbeing Board at our next meeting. And in this area as well, there will also be a focus on supporting the delivery of the physical activity framework, active travel, and all of that lovely stuff that's linked to placemaking. And the final one, D3, is healthy workplaces and economy. We want to strengthen the coordination of the existing programmes, such as the Work Well programme, Connect to Work, and Healthy Workplaces. So sharing insights and unlocking those challenges to support people to stay in and return to work. The next priority, there is a gap for healthy homes, so we will be addressing that in the coming months. But in terms of healthy and safe communities, this is a new commitment for us, and we will start by understanding what work is already underway across the partnerships, joining up that working, sharing the learning again, and having those collaborative engagement approaches, leveraging the voluntary sector and looking at our lived experiences within our communities, and deliver that coordinated support to existing initiatives and emerging ones as well. We have a really strong partnership within Staying Healthy, including police, fire, voluntary sector, community and resilience colleagues and partners, so hoping to make really positive progress in this area. And the final two, E1, oh sorry, I've not changed my slide, bear with me. enabling healthy choices and behaviours. So we want to really address the challenges in delivering the sexual health and drug and alcohol strategic plans. So there are really strong established partnerships within this area already delivering this work. And the Staying Healthy Partnership will assist in adding value to the work that's already happening in this space. For example, improving testing and access to those populations that are difficult to reach. We also want to work in partnership to prevent harmful gambling and promote screening and signposting for those in need of treatments and support. And to support the delivery, again, of our physical activity framework, creating appropriate opportunities and pathways and supporting others, also partners around the table in accessing our physical activity offers. And the final one, E2, is around healthy weight, food and nutrition. Our final commitment there, we want to work together to achieve the Gold Sustainable Food Places Award. It's a bit of a challenge. It's not easy to achieve, but that's our aim for this piece of work. And we also want to strengthen and expand our whole system approach to healthy weight, food and nutrition. Again, this was an agreed priority within the development session back in 2024. And work is really progressing well in this space, and we'll provide a detailed update for you at our next Health and Wellbeing Board in June and show what impact we're making on that level. So now I'm going to hand over to Lisa, who will describe the Living and Supported Well delivery plan.
Thanks, Abby. Okay, so we've had the draft of this high-level plan go to our integration exec in January, and you can see that the first section that we've got is around upscaling prevention and self-care. The commitments within this centre around things like empowering self-care, access to services, independence, and supporting people to remain at home, falls prevention and support for carers. The actions align to our neighbourhood care offer that we're developing at the moment with partners across Leicestershire, in particular with West Leicestershire Implemented Site. We've got things around housing and the expansion of assistive technology within supporting independence. We're looking at specific services and improving the commission services for falls management and prevention of admissions due to falls. And we've got support for carers, all of which are either directly supported or commissioned and form part of the Better Care Fund. The second section is around the management of frailty and complex care, and we've got three commitments, bless you. We've got three commitments that sit within that. The first one is around early identification of need, and this is where we're looking at sort of the higher level and complex care for people that utilising population health management data for people that have got quite complex needs and would be in sort of patient need groups 9, 10 and 11 to ensure that they're maintained to stay at home as part of the neighbourhood focus. Supporting independent living points towards the kind of single point of access and crisis response services, again, making sure that we've got the right level of capacity to have good intermediate care services. Continued development of the personalised care framework, which is where we jointly deliver health and social care tasks between us, and looking at some of the hub and spoke models that are out there around the voluntary sector to support some of that high level need and complex care. Again, most of these are funded and or commissioned within our Better Care Fund. Thank you.
Thank you, Lisa. And finally, we have Kerry Cole with us today, leading on the Dying Well priority delivery plan.
Thanks, Abby. So a number of commitments noted in the delivery plan, and a draft has gone to the integration exec in January, but really important to recognise that the commitments are very much aligned to our LLR, end of life and palliative care strategy that has been worked on with our partners organisations, but most importantly with engagement from the public, our patients, the people that use our services. Some of those commitments is absolutely around joined up support and how we improve health and care services to work together at the end of life, at somebody's end of life, making support more joined up and easier to navigate. We have heard from our insights work and our engagement work of how fragmented some of those services can be in terms of not knowing what's happened throughout that journey, so repeated conversations, etc. And actually, when we're looking at care planning and respect plans, why haven't we got a shared digital platform so colleagues, professionals know what's happened or what's going to happen next? So one of our actions throughout this work will be to implement a shared digital platform, and that work has already progressed. Also important to recognise that the 6 work streams that are working on behalf of the work that we've described here have got representation from each organisation, partner organisation, etc., and are driving that work in terms of it being consistent and joined up, and looking at actually where those improvements can be made across the system, across those organisations. The other kind of commitment around making end-of-life conversations a normal part of life is around the insights work that we've done around people telling us that they want to have those conversations earlier on. How do we plan for that situation or for that stage? And how do we make it as easy as possible for them to gain support or get support, access to support when they need it? So we have already done some education classes as a proactive public engagement offer, and we intend to continue to do this through the comms and engagement work stream, to normalise end-of-life conversations and actually give people the confidence to make informed choices. The other commitment that's been noted is understanding what matters at the end of somebody's life, and we will use data and insights to better understand what matters to people most, and how we shape the care and support that is planned for them and delivered. Now, this was a real gap for us when we first started the strategy work. We recognise that our data is lacking in certain areas, and how we need to ensure that we have a dashboard that allows that data to be captured, but not just in a numbers format, but actually quality. And what does that mean for the people that we serve and the services that are being supported in the way that we need to. We've actually increased provision within our end-of-life and palliative care support, and we've recognised that there are certain elements that weren't working previously. So how do we continue to look at what works, and actually what does the success of that look like, and then how do we make those changes as we continue to do this work going forward? The other element is around bereavement support, and making sure that we have those services accessible to people that need to use them. So yes, within the system, within Leicestershire, we have a number of bereavement services, but actually we don't always advertise them or make them available so people know what's there, so what they can access. So we are currently looking at the exact services that we've got in place, but also looking at how people can access them in a seamless manner and make sure that carers have got the support that they need as and when they need them. And this isn't always just as soon as something happens to a loved one. That grief, it happens in stages, so making sure that they've got that support throughout a longer period of time as and when they need it, really. So those are some of the main commitments and our actions. We continue to work with our partners through those work streams and through the task force that we've got in place. And we will continue to kind of review those actions. But most importantly, as Fiona mentioned before, we look at those commitments and actions, but how do we measure those successes? And I think that's really key in this area. And we need to make sure that we're looking at those successes in different ways and ensuring that our diverse communities also access those support services as and when they need to. So we'll continue to work on that as we progress this work. Thank you.
Thank you, Kerry. And just a couple of the cross-cutting themes here in terms of health inequalities. With all our delivery and actions, we want to ensure that they're designed in ways that focus on groups and communities experiencing the greatest disadvantage. So there'll be a heavy focus on that when we are developing the operational delivery plans that sit under this high-level plan here. And the final cross-cutting priority is a new priority. It replaced, as you remember, the COVID-19 recovery priority. So partners will work together to support vaccination and screening programmes by sharing those insights, addressing challenges and enabling that consistent approach, including co-production that encourage inclusive, positive behavioural change. So that's a key area that we want to take forward over the next 12 months. So subject to approval of the amends of the Joint Local Health and Wellbeing Strategy, the approval of the easy read version and the delivery plan, that is the ask of board today really, and any of your feedback will be welcome. Thank you.
Thank you very much. Kevin, would you like to ask your question?
I think I know the answer to this, but usually I'm wrong, so bear with me. With regards to progress reports, I'm taking it that basically that cycle will continue, will it, if you're saying that? But if that's the case, what happens if we can have like a mop-up's probably not the right word, but would there be opportunity to have like an end of year review for all 4 areas that we're going to get the progress reports for, just in case any benchmarking or data or anything, we may look at something and go, well, actually, is that target too high? Are we maybe being not realistic here, or something else has come left field that we now need to take into consideration?
In terms of the subgroups, they will be monitoring the plan on a quarterly basis. So they'll be reviewing the actions, the targets, along with the new dashboards that are being developed by my colleague, Victoria, that we'll be talking to you in a moment. And we will continue to have the annual update, so more of a deep dive around each one, and we'll have an annual report as well, which will include the revised delivery plan.
Thanks. It's a really detailed plan. A few times you've made references to things like A&E attendances and how we can, as it were, improve that aspect. And we've heard of the interdependence with Better Care Fund. So I'm coming this from a really simple perspective, because I'm the finance officer for the ICB. I like to be able to thread through value in all the things we do. So when you reference outcomes, and it might be to the dashboard that we're really talking to here, I'm keen very simply to understand how well we're able to thread through cause and effect. So we're doing something different. We're, as it were, addressing a need within this cohort, and we can see evidence, or we can point to evidence that action's having a success or making a difference. So my question is really quite simple. How do we actually get a hold of how well these plans are being implemented, and the outcomes that we're looking for are being delivered in a way that makes it really evident that we can point to that and say, that's successful, and there'll be other things that it's not working quite the way we expected. Is that going to be very evident to us through the reporting, either into the Better Care Fund or back to the Health and Wellbeing Board? Because that, to me, is the acid test of whether we're delivering value for our population.
In the report pack, there is our success measures that are aligned to each action, and also an indicator within the dashboard, the fingertips work. So we can see some areas it's quite complicated when we're looking at reducing obesity, for example, because there's lots of elements to that. But what we intend to do in the individual projects is actually drill down some outcome-focused, project-specific outcomes that will feed back as part of our update as well. And then we can see the bigger impacts on where we are red at the moment in terms of obesity in Leicestershire. There's also the Better Care Fund outcomes that will be aligned in our dashboard, and we're working very closely with our business intelligence colleagues to ensure that not only we have the fingertips data, but we also have the Better Care Fund data as well. In addition to that, we'll have qualitative data, because as Kerry quite rightly said, in the dying well space, there isn't that data available to us. So it will be lived experiences, case studies that we'll bring forward, probably across the life course, as well as the qualitative data. Does that answer your question?
Proof of the pudding will be in the eating, I think. So let's just hold that thought. Thank you.
Chair. I was just going through them and having sat through the developing phase for most of them, really good outcomes, really good focused points. I was thinking about particularly around the supporting independent living, whether we haven't mentioned specifically the support given by housing in its broadest form. And I wonder whether we should link housing policy to that particular commitment, so that because housing is key to living independently, aside from the coming in with health and what have you. And I think it would be quite key just to align the dots there. And the other side of that is also the voluntary sector and linking. I'm not quite sure how we link a policy that confines the voluntary sector, because there'll be huge support for that in terms of independent living.
I think Stay and Healthy Partnership and the Integration Executive work closely together. There is a golden thread between all the subgroups, so there will be that line of sight with regards to what we're doing in housing and what the adaptation side of it as well with the IE, but we need to make sure that the right priorities are with the correct officers and partners.
Want me to add anything? Okay, so we've got as you know, Fiona, we've got a couple of different strands, haven't we? So there's supporting people when they have kind of complex care needs to live at home and remain independent, all the way through to helping people to have access to the right services that they need to enable them to live where they want to live, for example. Staying Healthy Partnership is much more on that kind of scale, and then within the integration exec we're looking at making sure that people stay independent, and that's sort of through things like as you know, we've got the whole of the DFG budget sits within the BCF, and we work with the district councils around providing light bulb. We've got the housing enablement team that works sort of with all of the hospitals and community hospitals. And then we've also got the things that we've got around independent living, around assistive technology, etc. So we think we've got most of the kind of housing needs covered in terms of the remit of the two different partnerships. But certainly, you know, you can come to me and we can have a look at if we've got any of those gaps that you're aware of from the voluntary sector and from Health Watch. I know that you've done some work with patients, particularly around discharge and discharge planning into housing and to enable people to get home okay. We also do commission the voluntary sector organisation to support people to get home from hospital. So we've got most of the pathway covered, but always open to any suggestions or anything that we've missed.
Thank you, Chair. I've had the privilege of being on the steering group, so I'm very comfortable with what's proposed. And Abby and colleagues did a great job pulling this all together. Just wanted to reflect on a point I've made before. Actually, it's noted in the covering paper at item 9, where it talks about work now commencing on the development of neighbourhood plans as an addendum, and I guess I can't overemphasize the importance of that next step. We had a development session focusing on what we call community health and wellbeing plans yesterday, and highlighting the fundamental importance of that kind of hub and spoke approach across Leicestershire, and then working in localities and neighbourhoods, and the powerful stories we heard from colleagues working across the system yesterday about local delivery. So yeah, really looking forward to see that come forward. I'll make the point I've made before again, which is the greater alignment we can have between ICB colleagues, local governments, the OPCC and other partners around what a neighbourhood is, and trying to create common frames of reference will just make partnership working at local level so much easier. So I look forward to that work developing and continue to support it. But it was really powerful stuff yesterday. I look forward to this being equally as powerful. Thank you, Chair.
Thank you very much. Any other questions? Oh, didn't see you there. Go ahead.
Okay. I've raised this before in relation to equalities and a focus on care leavers. We've made a commitment as a council to recognise care leavers as having a protected characteristic. I'm really concerned that they're not always on the forefront of thinking about accessibility of services for our care leavers, and yet they're known to have some of, nationally, the research is sound in terms of some of the worst health outcomes, and quite often what we perceive as what looks like accessible services are really not accessible services for our care leavers. So just, I suppose, a recommendation that when we are looking at equalities and we come back with reports, we have a clear line of sight of what that looks like and what that lens looks like for the strategy for care leavers.
Thank you very much. Okay then, thanks for your contributions, everybody. So I will propose that the board approves the change of wording to the Healthy Homes commitment in the Staying Healthy, Safe and Well life course priority, approves the easy read document and notes the joint local health and wellbeing strategy delivery plan. I have a seconder. Thank you. Looks like we're all in agreement. We've got lots of seconders. Everyone wants to second it. Excellent. So agenda item number 8 is the Better Care Fund Q3 update. This report provides the Q3 25 to 26 template report of the BCF. This report will be presented by Lisa Carter, Health and Social Care Integration Service Manager, Leicestershire County Council.
Okay, if I stay here, no, don't move over there. Okay, so this is basically the Q3 report, exactly the same as the previous 2 quarters in terms of what we have to return. Just as a note for the board, the Chief Executive of Leicestershire County Council approved the report using powers of delegation for the deadline of the 30th of January. The framework was released in December with a deadline of 4 weeks. It has exactly the same requirements in terms of tabs that you can see on the template return. It's about whether we're meeting the 4 national conditions, confidence on assessment of achieving the metrics, and an update on income and expenditure. So we are currently meeting all of the 4 national conditions. We have in section 10, outlining the current performance to date along with the BCF metrics. You can see we've got for the rates of admissions for Q3 so far, we have got improved performance against the plan, and year to date also that is the case. With delayed discharges, we're slightly off target in terms of discharge delays for all adult acute patients. The proportion of patients discharged from acute hospital is slightly lower. You can see we've got a target of 86.5% and 84.9% of people that are discharged on their discharge ready date. For those that aren't, we had a target of 3.22 days, but we're actually at 4.6 days. For long-term support needs for older people, and reducing the amount of people admitted to residential and nursing care homes. The plan was to have 217 admissions, and actually we're at 213, so that is good performance. We're actually, the data is still behind. We're only at November data at the moment, and that is published using a combination of SUS and adult social care data via the DHSC website. So you can see in the commentary section some of the things that we've highlighted as part of the performance, particularly against discharges. We do have overall data to show us how we are comparing with other East Midlands partners, and we are better against both the England average and the East Midlands average. However, we're obviously not resting on our laurels, and I've done a little bit of an extra return to our BCF colleagues to state some of the actions that we're taking to try and improve discharge and discharge timescales across our system with partners, and I'm doing that via the discharge subgroup of the UEC Ops group. Updated spend and activity section shows that we, for Q3, have got a published spend roughly in line with where we should be at Q3. We're actually at 73%. So we do recognise there is a slight amount of slippage. Through the integration exec, we have confirmed what we will be spending that slippage on indicatively. We've got slight overspend in adult social care in terms of assistive technology, so we want to put some of the funding towards that. Sorry, Ashley, we were going to be looking for some locum therapists for UHL, but unfortunately there aren't any. There's no such thing. So we've been trying to recruit now since January, well, actually since December. But we haven't been successful. So we're actually going to repurpose that money to support the MDT developments of neighbourhood models of care in the implementer sites. So we've got a small amount of slippage being utilised for that. Don't worry, we are looking at having something a bit more stable around fixed term contracts for supporting avoiding admissions through therapy for 26-27, hopefully, she says. And the third thing was that we are going to fund the shared care tasks that form part of packages of care, where a small amount of a package of care is utilised to do very low level healthcare tasks. So there's a little bit of everything, something for everybody in the slippage currently. Just as an aside, I will say that obviously since this report was written, we have had published the 26-27 guidance. There won't be a health and wellbeing board before that submission date, which is going to be the 19th of May. For the governance and sign off, that's going to be the May integration executive. We have done a development session as well on the 27th, which I think most of you were at, for the Better Care Fund. And I am really pleased to report that everything that we went through has kind of transpired in the planning requirements. So that's pretty lucky, breathing a sigh of relief. So just to let the board know that the Chief Executive will be using delegated powers again to sign that off for the submission in May.
Okay, thank you for your report. Any questions on that? Okay. Oh. Yes, Mr. Gaunt.
I just recall when I saw this at Q2, the average length of discharge delay was similarly, it was off track. I don't think there's any improvement. Have I got that right?
Yeah, no, there's not actually. I think there's been a slight decline, but we have got a couple of things that we've done as part of that partnership. One is around looking at comms with families and trying to ensure that there's timely decision making around discharges and discharge timescales, and also that's been approved by partners, and we've all contributed to that as well, to make sure that we can, wherever possible, help people with decision making for their onward care needs, and that's across all the pathways, including Pathway Zero. We have also looked at how we've done a piece of work looking at the pathways around early discharge planning. So one of the things that we can do around pathways 1 to 3 that's really effective is to early discharge plan. So before somebody is estimated discharge date, we are looking at the things that we can sort of put in place, particularly where we're working with care homes, because there's obviously quite complex decision making around whether someone's suitability to either return to a care home or go to a new care home. We do that really effectively with LPT. We have 100%, pretty much of the time, 100% of referrals come through before someone's EDD. We're about at 30% with UHL, so that we know that where we do that, we've done some work currently on that 30%. Where we do get that plan in early, we are much more likely to meet the discharge dates that we're looking for, which would get us into that target. So for things like Pathway 2, it's about 48 hours post discharge ready date. For Pathway 1, it's about 24 hours. So we've got a couple of things in train, but we are doing some more work, because the vast majority of discharge delays is not within the kind of partnership control. That Pathways 1 to 3 forms quite a small percentage, and this actually measures Pathway Zeros as well. So what I discussed yesterday at that UEC group around discharge is how we better manage and measure some of the Pathway Zeros, so that we can make some effective changes where we need to. So for example, at the moment, we don't report on how many Pathway Zeros form part of a delay, or how many on average days they are as a pathway on its own. And we do commission some services to support people to get home as well, utilising the voluntary sector both across city and county. So if we need to, we could look at how we could better develop that, but we need the data behind it. And we do pretty much all we can really with pathways 1 to 3, and particularly with the opening of things like Preston Lodge. That's helping to support some of the timeliness for that.
Thank you. I mean, you anticipate what was the back of mind, which is well, what's
That's my
driving
job,
it.
yeah.
And the obviously the UEC board is multi-partner, and its role is to look at performance in the round. Where we sit here, as you say, it's focused on those areas where the interaction between health and social care could create gaps, and it's that sort of stuff that we need to keep coming back to.
Yeah, exactly. And if you can help influence making sure that at that UEC ops group we have got the right levels of data, that would also be really useful. And you know, I'll certainly do my bit operationally to try and make sure we've got the right levels of measurements in place, because they're the thing. I normally have to do my own return to NHS England to say these are the reasons why we're doing it. I mean, it'd be much better if it came from all the partners, I think. So thank you very much.
Okay, so I'll propose that the performance against the BCF outcome metrics and the positive progress made in transforming health and care pathways up to Q3 be noted. Can I have a seconder, please? Lots of seconders again, so we're in agreement. That's great. Unless there's any objections, what I'd like to do is make a change in the order of business and bring up item 11, which is the ICB 5-year strategy. Presumably nobody has any objections. So this report informs of the contents of the 5-year strategic commissioning strategy. Pete Burnett, Chief Strategy Officer, ICB, is going to present the report.
Thank you, Chair, and thanks for inviting us in on this agenda item. So the 5-year strategy was a requirement set down by NHS England to all ICBs to develop a 5-year kind of commissioning strategy, which we started commencing that work in October. And I should say, obviously, previously the ICB covered just the LLR area. It now covers Northamptonshire as well. So the strategy covers the wider cluster area of the ICB. And I know you've got a further paper on the transformation of the ICBs going forward. It had 2 parts, really. One was to do a needs assessment across the whole population and identify kind of areas of health need that we might need to address as part of our commissioning priorities going forward. And then to identify what our kind of core priorities are as an ICB as we move over the next 5 years. So we did, so we started with the needs assessments. We looked at the health and wellbeing board strategies across the 5 upper tier authorities to see where there's commonality and consistency. We also went into our kind of population health data, which I know you've got in the pack, identifying kind of what the health needs were, what the demographic growth was, and what the impact that is in terms of the older Asian population being the biggest area of growth, impact on health inequalities and what matters in different communities in that respect, and also around children and young people, and certainly around mental health and kind of also condition specific kind of needs that appear within our communities. So we did that. We had the needs assessment. We had a number of sessions within health in terms of looking at kind of what does that mean and how should that shape our commissioning strategy going forward, and identified through that work that actually the areas we were going to focus on were going to be condition specific, so frailty, early mortality around CVD, respiratory and cancer, and also in children and young people's around mental health and neurodiversity in that sense. So they were agreed as our kind of our core priorities. Doesn't mean we're not going to be working forward on other agendas, but in terms of what the board is going to be focusing a lot of its time on will be those kind of 3 areas and what the organisation will be geared to in terms of moving forward. We then held a number of workshops within health and with members of public health attending around those 3 areas, one pre-Christmas to make sure, okay, what do we need to do in these areas, and then subsequently some 3 more workshops post-Christmas. The biggest challenge, we had a date to submit a strategy to NHS England, which is February. So there's more work to do. I shouldn't say it isn't a fait accompli in terms of they are in terms of the priorities, and that's been to our ICB board for approval. But we're not saying the document there's more work to do in the priority areas as we go forward. But those workshops really kind of pulled out kind of the key ideas and key areas we need to work on going forward. That was also presented to the clinical executive meeting across the kind of North Hampshire and Leicestershire area, and was fully supported by the clinicians. We had quite a broad range of clinicians at that meeting who gave it a ring endorsement in terms of where we got to. So that's what we come up to, and that's what's undertake. Obviously, we read the strategy that was included along with the needs assessment. They're going to be our priorities going forward. The key next steps is mobilising around those priorities now, notwithstanding the ICB management of change process going forward, which will end in the near future. Putting the governance structure in place, getting the partnership on board to kind of move those priorities forward. But as you'll notice in the pack, is in there a few times, but on page 132 there is a kind of a plan on the page that identifies as within that strategy they are our three core kind of priorities. But alongside that, there is partnership work on the right-hand side, because that's going to be vital to deliver this. It's not about delivering this in silos. And it also doesn't mean we won't work on community kind of health and wellbeing plans where they might have kind of slightly differing priorities within that. That doesn't mean we can't support that going forward. And on the left-hand side of that kind of plan on the page, there's our core commissioning requirements that are mandated to us by NHS England. So alongside developing the strategy, we also did our operational planning work with our provider colleagues, which was submitted on the same day as the strategy was to NHS England. That core commissioning will still take place. It just means as an organisation, we'll also have a specific focus on the priorities as outlined here. So that's the document. That's we're taking this to all the health and wellbeing boards, clearly, where we welcome your views, and that will help shape the next steps as we move forward. Thank you.
Go ahead. And yeah, cheers. Thanks, Chair. Cheers, Pete. So a couple for me, one of which was mental health. So children's mental health is in there, and issues around neurodiversity, but not adults. Query, question mark. So where does adult mental health feature in the kind of list? And then it's probably blurs into a conversation about ICB transformation, because it talks about a strategic commissioning plan for NHS services. But then clearly some of the drivers that flags up in the strategy are broader stuff, sort of, you know, it's like a beast here, isn't it? It's public health territory. So I don't know if it's correct about the commissioning strategy or the future direction of the ICB, but I'm assuming, you know, sticking to the knitting. The knitting is sticking to the commissioning of NHS services as opposed to having a commissioning brief outside. If you see what I mean, it's almost like what's the scope of the ICB and more specifically this plan around commissioning.
So mental health remains a core commissioning requirement for us to do, and we'll work with our provider colleagues in terms of how we move that forward. And there's obviously other services provided by other organisations in the mental health field. But the key with the strategy is you do need to prioritise, otherwise and hang down what's really going to be our focus. So within mental health, it will be the neurodiversity and mental health needs, because you can see the long-term impact of that, as you'll know, over if they go into from adolescence into adulthood, that can maintain for some time. So it's a key focus of addressing that. Doesn't mean we're not interested in mental health elsewhere, and we won't be carrying on commissioning mental health services and looking to develop them going forward. So that's where that comes from. In terms of our strategic commissioning plan and how we do this, some of this has to be done beneficial to do in partnership. So it's the preventative stuff that we could work together on and joint commissioning and see how do we kind of pool our assets, because we're all, as public sector organisations, feeling the squeeze, as we'd always generally say, but there is benefit by working together on kind of our priorities and well, how can we work together on our commissioning work? So if we put that money together, we have a better bang for our buck and join up those plans. So that's going to take time to work through, but that's how we see it going forward.
Thanks, Chair. Just, I mean, Pete's answered the point, but it's probably worth emphasising. In Leicestershire, we're coming from a position of essentially an underlying deficit position of something like £42 million. Okay, and so we start the year in the red, so to speak. We're going to post a deficit of around that area in the financial year that's about to end. So in doing the prioritisation, as Pete's outlined, what we're really saying is, if we don't focus on these things, we are never going to achieve financial sustainability, because we're seeing enormous pressures throughout all aspects of the service in respect of those populations, those cohorts that are using the services. Clearly, urgent emergency care is a big draw on our resources. About 1 in every £5 of NHS spend in Leicestershire is on urgent care. So being able to implement some of the things that Pete was outlining is going to have a big, we believe, is going to have a big shift in the trajectory, which is then going to put us in a really far more likely to be in a sustainable financial position. And financial position sustainability is sustainability for the whole service. I hope that's helpful.
Thanks very much. Obviously, the question was asked in respect of colleagues, Abby, Kerry, Lisa, etc. So just in respect of the strategy outcomes and them being measured against value for money, how do you offset that in respect of good quality services and positive outcomes for those people in receipt of services, but also the wider health and social care economy?
I'll have a go at picking up. There's the notion of value in healthcare is something that we don't talk a lot about, and you'd expect a finance person to talk about what things cost, how we can make efficiencies and what have you, which I do talk about. However, it is much more important for us to understand the value that we derive for the population for the things we commission. And undoubtedly, well, we could go through the list, but there are things that we commission that actually are very tangential to our mandate. And you've got to ask yourself why we commission them and why we're deploying NHS resources into them. There are things that we commission of clear and absolute value for our population, and we would want to do more of that if we could only afford to. There are things that we would look at and say it is hard to see how that adds value. So clearly we would seek to remove expenditure from that and put them into the category above. But there's an awful lot of expenditure where it's difficult for us to assign value to them because, well, I think, Abby, you said it earlier, and sometimes you look at an outcome and it's so complex to work out if something's working or not for the population, the individual, because there are so many things that are a variant in that outcome. So we are trying to find a way of assigning value to everything we do. We've designed a framework called Commissioning for Value. It's something that's sort of very internal at the moment, but is balancing all the things you'd expect us to do. You know, outcomes for the individual, large population change, addressing future needs. We have to respond to government policy and mandate that's given to us, and equally financial constraints. So all of those things will play a part in what I refer to as balanced decision making. Hope that helps.
Chair. Hi, Pete, Fiona Barber, Healthwatch Leicester and Leicestershire. It's really hard work trying to pull a 5 years strategy together, and this has been a really interesting read. You referred to some data that has helped inform this. Was that data the JSNA? Or right, and how does the JSNA actually influence the information you've got in here? That's the first question. And the other thing was you talked about identifying priorities, and I guess given what Matt Gaunt has said, that's quite logical. And I guess many people out in our communities would agree because they know that the NHS is absolutely strapped for cash. But a lot of people out in communities feel they have a big stake in part of the NHS delivered locally, and this will clearly impact on what services people can access, how quickly they can access them, and so forth. So I guess from a Healthwatch perspective, it would be very interesting to learn how you've involved communities locally in developing this particular strategic approach, given that it will be impacted upon them. And many people have quite an intelligent thinking around the NHS, and they don't naturally expect services to the nth degree. They would like to contribute to the discussion around how things are prioritised, given that they'll be impacted by them. And that links in really to the value question that was asked, because people do have or put a value on it, and of course it does help generate better communities and more resilient communities down the line. So really it's about JSNA. Where does that sit with this? And how did you use communities to help you identify your priorities? Thank you.
Yeah, no, thank you, Fiona. So two things. So the JSNAs underpin the Health and Wellbeing Board strategies, and therefore, because obviously in their local, they're for the local area that the Health and Wellbeing Board strategies for. Also, we're doing it on a cluster-wide basis. So there isn't a JSNA you can look at, because we'd have to look at all 5 areas. But we did look at the Health and Wellbeing Board strategies, compare and contrast, and pull that out, and you look at the data within that. So that was part of the needs assessment at the start, to do that piece of work. So that happened in that respect, rather than looking at each JSNA for each of the 5 upper tier councils, because that wouldn't be achievable within the time frame we were given. And in terms of public, in terms of the public voice going into this, the challenge you have within NHS timelines is that actually, yes, it needs more public voice going into the document. I'm not going to disagree with that at all. And the public voice, certainly as we go out and shape how we deliver the priorities, is going to be crucial, because otherwise you commission services that don't meet people's needs because you haven't reflected their kind of lived experience. So we're not trying to move away from that. We do have a database of all the engagement work we do across the both kind of ICB areas, and that has then fed into kind of what the feedback has come through that engagement work to kind of underpin the work. But I'm not going to sit here and say that's perfectly nicely done and wrapped up. It isn't. There's more work we can do, because we get given from October to suddenly identify what priorities are and then submit a plan in February. It's got to be all written up and tied in the bow. That doesn't lead to meaningful engagement and involvement. So we need to do more of that as we go forward, and as we develop how we're going to deliver on those priorities. It's key that we involve people from the local communities that are the kind of areas we want to focus on in the first instance, to make sure what we do deliver is going to have an impact.
Hi, Pete. It's just a quick one for me, which is, it sounds great saying about how the sector, the VCSC, needs to be in strong partnership with yourselves. But actually, when it comes to it, we don't seem to be, because it seems to be at times, not you personally, but that we have had issues, and we still have issues around things like, we're expected to pick things up for nothing. We're expected to deliver things for nothing, but without us, you can't do certain things. So I think it's just a slight concern I've got, which is, I agree with the fact that delivering the strategy, implementing it and everything, yes, you need us as a sector there with you. But I think if I can just put a marker down, I think we do need to have a conversation with yourselves at the ICB about not saying, we want a huge chunk of money coming our way, but that realism and that realistic discussion about what have we actually currently got as a sector that we can help to work with and enable what you're trying to deliver locally, especially down at neighbourhood level, and where are the opportunities where maybe we could jointly fund, we could jointly bid to try and actually do the best for the local residents. I think for me, that's just missing a little bit.
I don't disagree, and you've got an item later on the ICB transformation. So notwithstanding that reduces our headcount capacity by a third in terms of going through that, I think the fact that we've become a strategic commissioner and we're not on the pitch of provider kind of oversight and assurance and involved in the day-to-day delivery of, say, urgent emergency care or elective care and that kind of piece in the way we are currently, should free up our capacity to have those more kind of value, looking at outcome, looking at value, having the chance to come and work with you in that respect, because we're consumed with other priorities set there by NHS England. If they step into that space, free up our time, then we'll be able to have more valuable conversations and discussions and work through those programs together. There's a big if in that and see how it changes, but that is the intent of us becoming strategic commissioners.
I think as far as health goes, sustainability is the challenge of our age. And if there's anything you can come up with like this that supports that, then we've got to support it. So thank you very much. So I'll propose that the board notes the contents of the report, notes the 5-year strategic commissioning strategy. And that's it. Yes. Can I have a seconder? Thank you. All in favour? Just 1 second at this time. Okay, so we're going to go back. What I think would probably be best to do, because we've been running for an hour and a half now, is have a 10-minute break, which is the custom, and probably arrive back at 4:45. And then we'll be on item number 8. No, 9. So welcome back, everybody. So item 9 on the agenda is the GSNA Programme of Work proposal, which is on pages 89 to 92. This report provides an update on the joint strategic needs assessment work completed during 2025 using the revised dashboard-led approach. The report will be presented by Victoria Rice, Business Partner, Public Health Business Intelligence Service.
Hello everyone, thanks you for letting us present today. We're going to do a bit of a double act with myself talking about the progress so far and what we plan to go forward, and then a bit of show and tell of the dashboard that Amy has developed, which I'll pass on to afterwards. So, so far as part of the needs assessment, the joint strategic needs assessment, the main thing we have completed is a comprehensive needs assessment as part of the joint health and wellbeing strategy refresh that obviously Abby presented in December and has been to the board in various iterations throughout the process. As agreed by the board previously in 2024, we are now moving the JSNA process on to being easily updatable data dashboards so that interpretation is easier, we can update things more easily, and just sort of moving with the times in terms of data, because we did find the old approach with chapters, quite often you would publish a chapter and within maybe the month the data would update, and it would be really hard to update to keep it in line with what actually is going on in the world. As I mentioned before, we have started the process with a demography dashboard that will look at the data that underlies all of the different life stages that have been noted as the themes of the updated strategy. And as I mentioned, Amy will be presenting how that dashboard works shortly. Another thing we have done as part of the process so far is we've updated a inequalities dashboard that presented both census data and health data at an MSOA level. So that's middle super output area. And this was a dashboard produced in the last round of JSNAs, as it were, but we thought it was quite a good dashboard that is nice and easy to update, but also is really useful, particularly for work within the public health sphere. So we thought it was a great thing to sort of bring back, as it were. We are planning to use the, I feel I'm in the dark suddenly. We're planning to use the joint health and wellbeing strategy themes as the themes for the dashboard going forward. So that was why it's quite important to do that needs assessment as part of the strategy refresh. So that the strategy refresh can in turn inform the needs assessment priorities. We are hoping that we can get sign off from you today to set up a steering group to look at the sequencing of these themes. So we've got themes that we want to include, but maybe which ones we should start with, and when is probably best time to do it, because hopefully subject specific experts will know when data is published, and it just makes a little bit more sense to produce a dashboard when the data has been published rather than a month before and having to update it again. As much as we want these dashboards to be easily updatable, a bit of common sense makes sense. We also want this steering group to maybe inform if there's anything we think might be missing based off any gaps that aren't completely covered by the themes. One in particular that we thought of is maybe some mortality data, because we know that will not be included in the end of life strategy based JSNA, as it's a bit of a different topic, but we thought it was worth including that in some format, be it a full JSNA dashboard or some other analytical product. We also want to, at the end of when we have the capacity to do so, do some forward-facing projections and hopefully maybe a little bit of the health economics that we haven't had the time and capacity to bring to the Health and Wellbeing Board, just because of how much intensive work used to go into the chapters of the JSNA. We are hoping that this steering group that we can get the go-ahead to go with will have representatives from the Health and Wellbeing Board, operational groups, partners across the system, partners in place and neighbourhood, so that we get a bit of everything and everyone has a bit of a say. And then once we've decided on the topics being looked at, we can go to the subject group for that topic, for the subject-specific experts, and what format might work best for either their data or the people looking at that data from a JSNA perspective. So that's it from me. I'm going to hand over for Amy's show and tell.
Thank you. So this that you can see on the screen here is the first dashboard that we've created under the new JSNA process. So this is the Leicestershire JSNA demography dashboard. This dashboard outlines the demographic characteristics of the population of Leicestershire, and it includes a range of visualizations of the data as well as key narrative. So I won't go through all of the data just because there is so much included, but I'll just give you a kind of idea of the range of data that's been included and then highlight some of the key features of the dashboard. So this is the introduction page here, and you can see that the dashboard was created in December, and we've included a last updated date here, which was February. That's a benefit of the new dashboard approach, is that we've already been able to update the life expectancy data in this dashboard that was updated since we created it in December. You'll see that there's a contents page here, and you can navigate the dashboard using the tabs at the top. So if I just move on to the population tab, so this is the population data, the population view, sorry, and it presents population data by age and sex for the Leicestershire districts, Leicestershire as a whole, and then there's also some data for England on this tab too. On each of the tabs, on each of the views across the dashboard, you'll find an area filter. So each of the views includes district level data and then also data for the whole of Leicestershire. And you can use this to filter some or all of the charts. And it also filters the narrative at the top here. So we've included some key narrative to kind of bring out and pull out the key points that you'll find in the charts. And the top part tends to be filterable using that area filter, and then the lower sections of the narrative tends to be some district comparisons. So for example, in this view, we're pulling out the area with the largest population, or the area with the largest proportion of people from specific age groups, for example. Across each of the some of the views, sorry, we've also got a measure filter. So for some of the data, it's useful to have the data as counts, so that you can, if you're interested in pulling out the raw counts, you can do that using that filter, or present the data as percentages like in that chart there. We've also included a MSOA, so a middle layer super output area population tab. So this includes, again, population data by age and sex, but this time the data is filterable by MSOA. So this is helpful if you want to look at the data for a specific MSOA and compare the population size and profile across individual MSOAs, but we've also created the dashboard so that you can select multiple MSOAs, both within specific districts and then also across specific districts as well, so that if people were interested in, for example, looking at the MSOAs within a neighbourhood, you could do that and aggregate the data there. We've also got tooltips added to the data, so you'll see if you hover over the different charts on the dashboard, it will provide you with either some more specific information, or it will pull out some key narrative. So for example, here you can see that in 2024, there were 298 females aged 75 to 79 years old in the selected MSOA, which at the moment is Blaby Village, for example. We've also pulled in population projections data. So again, looking at populations projections over time, and you'll see again that we've got that area filter coming through. We've got a measure filter. And again, if you hover over the key elements of the chart, you'll get a tooltip, sorry, which will give you the key information, as well as that detailed narrative that you can pull out and put into your own reports if that's useful. We've also pulled through a tab on ethnicity. So we've pulled in broad and detailed ethnicity data. We're looking at the broad ethnic groups by age in this chart here. And then we've also looked at some MSOA level ethnicity data. And again, we've got that narrative included. We've also then got data on religion and language. We've pulled in some deprivation data. And on this view, we've looked at the data by LSOA in the map on the right here. And then also pulled in some ONS population estimates by IMD decile, so that if people are interested, they can look at the number of people or the percentage of the population living in more or less deprived areas. And then we've also pulled in some rurality data, life expectancy data, healthy life expectancy data, and then finally we've got a view on mortality. The mortality view also includes a sex filter, so that if you're interested, you can look at the data for all people and then split by males and females. So here, for example, we're looking at the mortality rate from all causes in females in Harborough, and then we've also included the top 10 leading causes of death, again with that key narrative coming through on each of the views. And then finally, we've just got the metadata tab. So this just includes the key data sources that we've used across the different topics, and then also provides any links to other helpful sources, including some other dashboards that we've created that might be relevant to the individual topics. So as I say, there's a lot of data in there for people to explore, but hopefully that's given you an idea of the range of data that we've been able to include in the dashboard, and then also some of the key elements, such as the narrative that run alongside the visualizations.
Thank you. I mean, they do say a picture paints 1,000 words, and when you can see the demographic changes just there visually, I mean, I'm sure there's more than 2,000 words anyway, 1,000 words anyway, but it's really good actually to have that data and just to be able to visually see where is the hotspots for, you know, whatever demographic you might be targeting at the time. Does anybody have any questions on that? No, no question. Oh, well, we're kind of half up, half down. Go ahead.
Probably up. Thanks, Chair. A couple of ones from me. It's one about the dashboard and then one about the paper. The subgroup, are we being asked to delegate taking forward everything to the subgroup, as in go away, prioritize, do, and then tell us what you've done? Or are we being asked that a subgroup takes it forward and then comes back to Health and Wellbeing Board with a recommendation? So we'll answer that in the last bit.
I think it probably makes best sense if we go subgroup, make some decisions, bring it back and make sure we've got sign off from everyone here. I imagine there'll be quite a lot of overlap, but that just makes most sense, doesn't it really?
I'd agree. I think just from my point of view on what the board to have oversight of what was decided, and there might be topics which we might disagree on. And then a couple of points on the dashboard which sort of looked really good. More broadly, we got a plan in terms of making it known to partner organisations. Just think about Pete and the overlap with the ICB commissioning strategy, Matt's comments about value, because I think we can use an awful lot of that in value. And then I've got one more last technical question, but again, I'll let you answer that one first.
So we haven't got an exact plan as of yet. It's one of the things we've wanted to bring up with the steering group, because it just seems like a great sort of do it all in one meeting, as it were. But also, I know that the ICB have put the links to our JSNAs on the NHS Futures website, and also from just making things easy for ICB, we're doing the same thing for Rutland, because we do this for Rutland. So the dashboards are very similar, which obviously can be quite helpful.
I think there's a real opportunity there, because one of the issues with JSNA is when it's static chapters, they go on LSR online, but I'm not certain how many people then download them. But if we can spread the message that there is an online dashboard that can be used for commissioning decisions, for voluntary sector bids and all the rest of it, then I think that would be a really good step forward. And I could ask loads of questions about the detail. It's like even the population pyramid, the first one, the days of calling it a population pyramid are long gone. I was going to comment on, you know, those pesky 55 to 59-year-olds that are the single biggest age group. The shrink down in the 20 to 24-year-olds, which look to be the you know, tight waist, if you like, with a big top, is that driven partly by Leicestershire's kind of student age population studying out of Leicestershire and moving their addresses, or is it a straightforward sense of there are less people in the in the 20s looking at that one?
I think it might have been that we were on a specific district without a university, because Amy's just flashing. There is a bit of a restriction, but less of a restriction now. Yeah, it was on Blaby. But I'll be entirely honest, it's something we need to look into if we want to have a look at that, because it's not something I could unpick off the top of my head.
Yeah, I mean, it tells its own story. Again, we probably should come back to that more often at Health and Wellbeing Board if you're looking at who's going to cost the state and who's contributing to taxes. So, make your own conclusions. You know.
Yeah, thanks again for that presentation. I thought it was really useful, especially for like the neighbourhood work that we're doing and things. So or supporting. I know I appreciate this isn't your responsibility at all in Leicestershire, but I always think when I see these kind of like really useful displays that it would be really good to have the same thing like for Leicester, for example. So I didn't know if you've got any insight into whether that's feasible or if there's any kind of partnership discussions around that.
So there is a fortnightly data cell meeting, which currently is only LLR. Whether or not it'll go cluster-wide, I do not know. But it is one of the things that we do sort of tend to discuss, because we were doing deprivation, they were doing deprivation, that sort of thing. It does make more sense to line things up. Obviously, we've got different work plans and priorities, so it is difficult, and also different software, which can be quite a big issue. But it's definitely one of the things we wanted to sort of think about. Just makes a bit more sense rather than doubling up all the work. Maybe we pick some things up and they pick up some bits for us, but that's just an idea.
Thank you. It looks like a great tool, and someone like me could get lost in the data and pursue the wormholes into insights, which is why it's useful if we're able to lift it up and present back a sort of almost one version of the truth. Where we sometimes get unstuck in our respective views of the world is where DPH says, well, these are clearly the priorities, and someone from an ICB says, these are clearly the priorities, and you think, well, they look quite close, but they're not exactly the same. And if we're all looking at the same stuff in the same way, we should come to the same conclusions. So my plea is that we find a way of doing that, and I think Pete is the man as our head of analytics and population health. But it's how we bring the views together, because equally our partners, I'm sure LPT might have their own views. So it's how we bring that together, and I think it by necessity it is senior people that need to kind of bring that together. With the greatest of respect to all the colleagues who've been involved to date, you kind of need to get them in the room just to frame it from the start, I think.
I think that's a fair point, and you know, again, the steering group could advise. But if I think about how we've had some good discussions when chapters are being presented to the Health and Wellbeing Board, that's one way of doing it. We might want to have a session in advance. You know, sometimes you could take a bit. You know, it takes a bit of sharing views on what we think is important, rather than just have Victoria and Amy present and we go, yeah, that's great. But I mean, it comes back to what do we want to do with this? And the whole point is we should be using it to drive all our business. And some of that's about agreeing on what do we think are the main issues. So let's pick it up outside, because there is a piece emerging for me about implementation of the JSNA, which the dashboard enables to be a bit different. And the current drivers around reorganisation, the ICB, give a bit of a impetus to that as well.
Okay, so I will propose that the board approves the establishment of a JSNA steering group to undertake the prioritisation and sequencing of JSNA topics, which will guide the ongoing development and programme of work. That officers be requested to note the feedback provided on the new demography dashboard. Thank you very much. Oh, we do need to vote on it. Sorry, my mistake. Seconder. Yeah, okay, we're in vote. Now you can go. Right, okay, so agenda item number 10 is the UHL clinical strategy, which is on pages 93 to 126. This report provides an overview of the UHL's clinical strategy 2025 to 2035. Ashley Epps, Head of Strategy, UHL, will present.
Yeah, thank you for your time. So this report provides, as you said, an overview of our group clinical strategy. So ours in terms of University Hospitals of Leicester, but also University Hospitals of Northamptonshire. We're in a sort of group model and have been since late 2023. So it's basically to share with you some of the initial progress we've made in sort of shaping and delivering that strategy, and obviously to consider any opportunities to strengthen alignment with the joint health and wellbeing strategy and support clinical strategy delivery. So I'm sure everyone is aware of this kind of context, but just as a, I suppose, a refresh, paragraphs 1 to 4 of the report outline some of the national context. So highlighting obviously the Darcy report and the findings around the NHS being in critical condition, with declining population health and satisfaction with healthcare services, particularly in terms of people struggling to access GP appointments and rises in acute waiting lists. There's obviously chronic underinvestment has been in capital in the NHS, which has led to outdated buildings and infrastructure, and that hampers productivity. And revenue growth hasn't quite matched the rises in demand that we see from factors like an aging population as well as some of the increasing complexity that comes with that. So locally, paragraphs 5 to 11, we recognise a lot of those challenges, rising UEC demand in particular, placing significant pressure on our services. So Leicester Royal Infirmary is now, as I understand it, the busiest emergency department in the country. And obviously we recognise a lot of the financial kind of challenges locally as well. In the report, it goes through some of the changes we've made. So I'll just briefly touch on those before introducing the strategy. So we've made a lot of progress in improving service access, quality and safety, as well as our efficiency and productivity. So our A&E 4-hour performance is in compliance, ensuring that people, when they attend emergency departments, they're seen within 4 hours. That's improving consistently. We've had significant 57% reduction in long waits for diagnostics in planned care, and massive improvements in maternity. So there's a regional heat map score that you may be aware of, which kind of rates maternity sort of providers across the region in terms of the quality and safety of services. A lower score is better, and our score has more than halved in recent years. So we're definitely, and we're in the green now, as I understand it. So definitely improving there. There's a few other things that are in the report about improving efficiency, etc., but I won't dwell on those. But yeah, so to emphasise that the establishment of the group model with Northamptonshire is really one of the main drivers of development of the clinical strategy. So there's massive opportunities through that group model to not only build consistency in how care is provided across the two areas, but also improve our operational efficiency, such as by securing economies of scale. For example, if we jointly procure things like consumables, and also to generally share good practice and build kind of innovative care pathways across the region. So the strategy obviously also links and aligns closely with the 10-year plan and the 3 kind of key shifts. I'll go through that in further detail. So yeah, and also the life course priorities, obviously, of the joint health and wellbeing strategy, and some of the key themes that have been discussed today, I think, are very much reflected in the clinical strategy as well. So the clinical strategy focuses on 6 key areas. I'll just go through each of those. There's kind of a work stream underpinning each of those as well. And there's an underlying emphasis throughout on prevention, ensuring equity in care provision, ensuring care is personalised, and also obviously clinically effective and efficient. So safe and sustainable services is our first kind of core work stream. And that, as it says, aims to enhance the sustainability of specialties across the group. So a lot of the work in that sort of work stream is about bringing clinical specialties together to develop their own kind of joint care pathways, and sort of share resources, share learning, as I said, secure economies of scale, and also make sure that the kind of service configurations for those specialties kind of make sense now that we're operating on a larger footprint, and that each kind of patient has kind of equal access, so isn't too far away located from services. Part of that, in terms of making sure patients have a consistent experience, means that we're exploring things like a shared electronic patient record, establishing kind of single points of access for referrals, and also single patient tracking lists and things, all of which will just help to kind of oversee and manage patients across the larger footprint. So that work stream's had initial successes so far in focusing on some of our more fragile specialties. So that includes, and I say fragile, it means obviously the specialties that have sustainability risks or things like workforce shortages. So it's initially focused on plastic surgery, hematology, spinal surgery, and nuclear medicine. And each of those has kind of been supported to develop its own joint group level collaboration plan. And we're next going to focus on, most likely focus on pathology and imaging. And as part of that, as part of all these discussions, really, we consider the role of digital as well in improving access and productivity. So, for example, with imaging, potentially exploring the use of AI to support with sort of screening and things like that. But also generally there's things like obviously virtual wards, remote monitoring technologies and things that could be relevant to many specialties. So the second work stream is frailty and long-term conditions. So obviously it's a major contributor to UEC demand and complexity. Often patients with frailty are admitted to hospital unnecessarily, and that leads to further functional decline, as you'll be aware. So the work stream is focusing on developing kind of primary and secondary prevention programs, including exploring the use of like predictive analytics to identify and target for support any vulnerable cohorts in the community. It's looking at establishing enhanced supports to allow or support people to stay in their homes, people with frailty. So that could include community-based teams, as I said, sort of some of the remote monitoring technologies and things. And then we're also obviously looking at developing more frailty-attuned kind of hospital services and looking at how we join up frailty pathways across settings. So currently this work stream to date has developed a sort of 5-year frailty commissioning strategy and a series of interventions which basically focus on the care close to home kind of agenda, coordinated support, so better coordinating between agencies, developing rapid hospital-based assessments without obviously recourse to admission unless necessary, and improving kind of recovery and step down sort of services. The third work stream is about neighbourhoods. So obviously really welcome the development of system governance around this, because I think it's been mentioned today, there's that risk of sort of divergence of approaches to some extent in terms of how we define the neighbourhood approach and which communities we target and things. So I think that will really help to prevent that from materialising. So the work stream focuses on not only sort of developing and shaping the neighbourhood care approach across LLR and Northamptonshire, but also how we're going to play our part in improving population health in collaboration with partners. One of the main things the work stream's done so far is kind of looking at our UEC demand and kind of mapping it to districts, starting with the city. So I understand that will be undertaken across the whole geography at some point, but it's kind of identified the hotspots for UEC demand in the city. So the areas, communities or neighbourhoods that we tend to get the most UEC demand from. And there's been kind of like a questionnaire at attendance with those cohorts to gauge the reasons why they've attended UEC and not potentially other areas of the health and care system. And through that, obviously, we're going to develop a sort of delivery plan and interventions to address some of that sort of disproportionate access demand. Very much keen to support the North West Leicestershire pilot and apply the lessons learned from that as well. And so, yeah, looking forward to hearing from that. And then the other key work streams, I just run through quickly. So maternity, neonates and children and young people, it's a major focus in the strategy. Obviously, there's a lot of national attention on it currently. I mentioned the kind of huge improvements we've made. Some of the services in maternity remain fragile due in part to workforce shortages. And in children's, I think, again, it's been mentioned today, there's issues around sort of things like dental decay, obesity, etc. So that work stream aims to bring the UHN group together to improve the quality and safety and sustainability of maternity services and improve equity of access and outcomes. So there's been an in-depth kind of review of performance and delivery across the piece, along with modelling of capacity versus demand. And that's all helping to shape, similarly to the first work stream around sustainable services, kind of shape a view on how these services should be configured in the future across LLR and Northamptonshire. And there's also a load of clinical engagement underway at the moment, and we'd welcome obviously partner engagement as part of that. So cancer is the next major work stream. So I'm sure you're all aware of the rising referrals and demand in that area, which is challenging our sustainability and performance position quite significantly. It's exacerbated by other challenges like regional shortages of oncologists and radiology equipment, etc. We do have strong partnership arrangements in place, like the East Midlands Cancer Alliance. But essentially, this work stream is all about basically trying to establish the group as home to the South East Midlands Cancer Service. So delivering a really modern, innovative cancer pathway, covering the whole cancer pathway across 2 trusts. And the workstream also covers a lot of the kind of dying well sort of focus area from the joint health and wellbeing strategy. So enhancing our palliative care provision, end of life care. The action plan has been produced and is focused on tackling unwarranted variation in care and expanding use of artificial intelligence, as well as strengthening multidisciplinary team working. And there will be a sort of partner cancer strategy conference in April to kind of review progress and confirm next steps. And the final work stream is about improving access, which is basically about obviously making sure that our planned care and UEC sort of services, primarily planned care really, are as accessible as possible. So we've made significant capital investments in recent years to improve our capacity in elective care. That includes the Hinckley Diagnostic Centre, the East Midlands Planned Care Centre, and the new endoscopy unit at the General Hospital. But demand continues to kind of grow. And so to meet that challenge, we obviously need to make sure that all of our sites are operating at optimal utilisation and productivity. And also in accordance with the 10-year plan, making sure that patients don't have to travel long distances to their routine appointments, diagnostics and minor procedures. And that includes obviously looking at virtual wards and things as well. So yeah, the initial priorities in that workstream are focused on digital and AI, also reviewing our information, advice and guidance sort of approach, particularly to try and improve how we provide information, advice and guidance to primary care to avoid unnecessary admissions, and redesigning specific specialty pathways, as well as developing elective hubs. So I think that was all I was going to present. It's probably more detail that was needed, but yeah, that's
Thank you. I thought you said elective pubs then for a moment. I was
no,
doesn't sound quite right, but it may be a good idea actually. Everybody goes to the pub, don't they? So yeah, thanks for the report. Very detailed. It's again, a lot of it is common sense. It's yeah. Thank you very much. Do we have any questions on that? Yes, do you know?
Thanks, Ashley. I mean, we had the presentation around the clinical strategy at LPT a couple of years ago now, I think it was, when it first came out. I suppose my query is just in terms of the report, what is UHL driven and what is actually driven by the ICB? Because quite a lot of the stuff in there around frailty has been an ongoing work stream that's been there for quite some time, looking at patient need groups, etc. And it just felt it's kind of overlapped a little bit, and I sort of lost my way in terms of what UHL, UHN are doing, what is being done by the ICB and that partnership.
Yeah, thanks. Yeah, I think that's definitely a sort of something across all the work streams. Is we're kind of trying to figure out essentially where we go as a group, and then how that aligns with partnership, existing partnership forums and things. So there's been a lot of mapping of existing forums and programs while we shape these priorities. I think in the frailty one, I need to double check, but I think there are plans to do wider partnership engagement on the frailty commissioning strategy, and also to shape some of those sort of delivery plans that sit under the kind of interventions that I mentioned. So, but yeah, I can take it back as something that needs to be.
Yeah, I think my worry in it is that, you know, we know that the delivery of really safe care out in the community, because that's what we do all the time, is done in conjunction with primary care colleagues. It's done in conjunction with the voluntary sector and with certainly social care. So I think it's just, I just want to make sure that we're not forgetting that, and that, you know, that whole collaboration piece is the key to sorting the frailty problem, I suppose, if you want to call it a problem, which I don't, but there we go.
Yeah, I mean, definitely, yeah, very committed to working in partnership. I mean, it's necessary for something like frailty and long-term conditions fundamentally. So, and some of those interventions do specifically focus on partnership work and like the coordinated support kind of. So, but yeah, I'll take that back. Thank you.
Sorry, I feel like I'm going to make a similar point to last time, but just picking up on focus area 3, delivering care in the communities and neighbourhoods, and recognising the point you made about welcoming that. So there's references to kind of the desire to integrate community-based care, recognise the improvements that makes, reducing mortality, emergency attendances, hospital admissions, bed days, complications, those kind of things, and that's where the kind of wider system beyond those areas that colleagues have already mentioned, things like housing, community support, stuff that is below social care intervention, but still adding value and preventative effort. And I'm just really aware at the moment, particularly with local government reorganisation, government has said to us that there needs to be a form of neighbourhood governance within all the new unitary councils that are created, but hasn't defined exactly what that is, what the geography it needs to serve is. So there is a fluid situation like there is within the ICBs. And I know we're going to hear a bit more about that in a moment, but I'm not clear where that conversation is happening within the system at the moment as to trying as far as we can, recognising constraints and PCNs and various existing structures do form impediments to that. Where is that conversation taking place? Now, maybe not a conversation for today, but it's just a question I posed to the board that are we clear on where that is happening? Because if we aren't, then guess what will happen? Things will move in divergent ways and it will get more complicated to unpick down the line. So it's a challenge, I suppose, I pose to the board and to the wider system about how we can make sure we definitely have that conversation in a really overt and transparent way to make sure that any choices that are made intentionally and with a full awareness of what's happening across the system within the ICB, local government and more generally. Thank you.
Yeah, thanks. Yeah, I think definitely completely echo that because, for example, I think with our focus currently on looking at UEC demand hotspots, that may vary slightly to some of the work that has been referenced about doing pathway specific kind of neighbourhood care. So, but I think, I don't know if Mike's maybe better placed to comment on it, but I think is there a paper around the development of a group, sorry, not group, system neighbourhood kind of governance group? I think that was.
I mean, potentially, I think for looking at Abby, but that's one of the things that we were talking about is having some kind of place-based group that builds on the event that myself and Ed were at yesterday around community health and wellbeing plans. I think coming back to the point that Jean made, I mean, I was going to echo that one as well, and I was thinking in terms of that place-based group whether you or a colleague would want to be involved, because similarly, I'm thinking from a health primary prevention point of view, we just need to make certain that what UHL want to do is aligned with all our thinking, and we'll never do. It's not even about you. No, one never wants to be in a position where a partner does something and you go, "I wished I'd known that before." And I think there is a scope for that group to act on behalf of Health and Wellbeing Board to have these broader conversations around governance of neighbourhood health model development in the context of LGR and governance structures around that. So probably making up in terms of reference in my head as I go along. But I mean, there is an open invite, I suspect, to even at the moment, the informal working group that we've got. Lisa and colleagues, Kerry, I think's gone, but might be worthwhile thinking about UHL's quite a role in that too.
Yeah, I mean, definitely be keen to contribute to that. Thanks.
Okay, thank you. If any further questions from anybody? No. Okay. So I'll propose that the board notes the clinical strategy, implementation progress to date and key next steps. Notes the strategy's alignment with the joint health and wellbeing strategy and the opportunities to support or enhance its delivery impact through partnership work. Can I have a seconder? Thank you. All those in agreement? Next item is item 12, which is the NHS transformation update on pages 109 to 174. This report relates to the structural changes that have been taking place within the ICBs and will be presented by Matt Gaunt.
Thank you. I was just listening to that little conversation, and I think it's probably worth going beyond just what's in the paper, the written part of the paper, which gives a very specific update on a process. And if I can point you to, I think it's slide 236 in the pack, which is titled Our Focus, a Strategic Commissioning Approach. I'm going to try and knit together some of the comments and observations made, particularly during the last item that Ashley set out, because the ICBs are being, I suppose, there's a new mandate, which is kind of a refinement of the previous mandate. Strategic commissioning to improve long-term population health outcomes, reduce inequalities where they exist, and building resilience and long-term sustainability with a focus on neighbourhood delivery. And in that, there's a lot of stuff in that. But each of us in our NHS partnership understand that there are specific roles for specific elements of it. Building neighbourhoods is going to sit with providers, but commissioning services for strategic outcomes is going to sit with the ICB. And there's a kind of new variant which is referred to in Ashley's document, which is integrated healthcare organisation, which is a bit of a misnomer because it's not an organisation; it's actually a contract, which is designed to glue elements of a health system together to improve better outcomes. And a previous version of this was the Better Care Fund, which was now 12 years, has been going for about 12 years, which was designed to integrate care to improve outcomes. So, you know, we've been on this journey for some time. If I can just focus on the strategic commissioning bit for the moment, because the slide, it sort of sets it out very simply. Understand your local context, develop a long-term population strategy, deliver it, and then evaluate the impact. That is going to be exclusively the work of the ICB, but partners obviously play a lot into that. And ultimately, you don't deliver services, partners deliver services. So it's all on you. But as I say, it's about understanding our unique role in it. And if I think about strategic commissioning, I've got a very simple way of explaining it. Understanding the local context, assessing the population health need today, but actually, if we're strategic, today isn't strategic. We're in it. So we're looking forward. We're looking forward over a time frame, and let's call it 5 to 10 years. And over that 5 to 10 year period, we have to assess what that future health need is. Working back from that, and as it were, comparing it to current provision will give us a few insights. I can tell you now, one of them will be that the nature of provision today to address the likely future need is just not going to work. It's not going to work because we simply don't have the capacity. I think I'm not wrong, Ashley, in thinking that we've virtually doubled our urgent emergency care use in our population over the last 5 or 6 years. I think that's not an exaggeration of it. So we have to then consider, if the population health need is a given, that future need, and whilst there's things we can do within our plans now which change the trajectory a little, fundamentally we need to think about how we set out to redesign future models of care to address that need that's 5 to 10 years away, because we can't do it with current provision. And that's where our clinicians come in. So the ICB will enable, facilitate clinicians come together from Ashley's organisation through, well, from all our partners, including the voluntary sector, to work out how we bring services up to date, as it were, or in a framing where they can deliver against that future health need. Because it's not through the existing model of care. There's going to be innovation, there's going to be changing clinical practice, and there's also going to be a look at where we set clinical thresholds to address risk in our services. So all those are part of it. Clinicians need to lead that. And then they will, as it were, price up. I say price up. They will set out the needs of a future health and care system. And then it will be my job to attempt to turn that into the provision base. So how currently provides the bulk of our healthcare through a very small number of organisations, and about 45% of the care we commission is through Ashley's organisation or organisations similar to it outside of the counties. So we need to consider how that model needs to change over future years. And that's what the population health strategy is going to have to address. How we understand the need, how we, as it were, interpret future clinical models, and how we translate those clinical models into a provider base today into something different in the future. And to do that, we're going to have to use our money differently, which is where the notion of left shift comes in. Left shift, put simply, is you stop waiting until people get so sick they have to turn up at A&E, and you intervene or manage. It's in your document, Ashley. You manage the conditions, individuals with multiple health conditions, more effectively to stop them ever exacerbating, so they turn up at the A&E department. And if we could do that one thing really, really well, it would unlock huge amount of resources to then put into innovation, into prevention, into a whole wide range of factors. So that's where we've got to get to, and you know, all of us have roles to play in that. If I pause there, what I'd say in respect to the other bit of our conversation is that all of us are saying the same thing. You know, if you were to present a strategy, it would probably say something very similar. We all understand we need to get to a position. It's about making sure we work on the things that we are most capable of addressing. And I think that's, again, where the ICB comes in, is trying to sort of provide a bit of context and glue between the different partners. Does that help? Thank you. Then in terms of the mechanics of where we are now, the paper, it describes a change that the ICB needs to make in its staffing model largely to address that new mandate, that refined and repointed mandate. And in so doing, if I'm honest, it's been driven largely by a financial target, which is to reduce, in our case, resources by around 30 to 35%, which means we have to take, broadly speaking, £17 million out of the cost base of the ICB. There's about whole-time equivalents, there's around about 500 folks working in the ICB. And whilst I've referred to it as a strategic organisation, there's a lot of operational. There's people who devise packages of care for people who need post-acute care into perpetuity. So we've got a lot of people, but we need to cut about 170 heads out. The paper describes the process by which we do that. It's about £16 million. We are now a little further on than the paper when I wrote it, where we're up to. We're about to close the consultation, and we've done 2 rounds of voluntary redundancy. In the 2 rounds of voluntary redundancy, we've probably got the majority of that headcount reduction. But because people have self-selected, it's arrived in places that you probably wouldn't agree to all of that, but that's a process we're going through, because we will find that there'll be too many people in some roles and there'll be big gaps in other roles. So we're at that stage. In March, we conclude and get all the feedback from the consultation that's been ongoing for about 6 weeks. And we turn that into an update to structures that we've published and consulted on. And then we will be effectively appointing into those structures. We believe we're going to get through that process by the end of June. There'll be a bit of a tail, because there'll be some people that are so critical to delivery of our service and our functions that we'll need to retain them for a bit. So there'll be a fuzzy transition period, which will probably extend through the summer. But when we get to autumn, we'll be an organisation with a really clear mandate, a much smaller headcount, and we'll be doing less stuff. But the less stuff we'll be doing is, we believe, the stuff that we don't need to do. And the paper goes into in some detail of things that are things that are going in certain directions. Some functions are going back to NHS England, so provider oversight isn't something the ICB does or will do. Those are the sorts of things that we do less of, but by any stretch, 30% reduction in headcount is a big challenge to manage. So your executive are fully committed, and we are working with some incredibly talented people to do the job. I'm very confident that we'll have a very strong team coming out of this, but I think it's pretty obvious there's going to be a lot of flux. Thank you. Happy to take any questions.
Bit of a tangent. I heard the acronym OPIC this week for the first one, the Office of Pan Integrated Commissioning. Either today or maybe as part of an update later on, it'd be nice to get an idea, I suppose, that there is the ICB changes, the strategic role that you set out, but I suppose where some of these kind of pseudo-regional functions kick in as well would be useful to know as well.
Let me just say something. I mean, it's a reasonably new thing. I sit on one of the executive feeder groups on the Midlands as a finance officer into OPIC, the Office of Pan ICB Commissioning. You'll be aware that NHS England are going through their own change. As part of that, a large swathe of services, let's just call them specialised commissioning, it's easier, but things that have been directly commissioned by NHS England, and it includes health and justice services and those aspects, are going to be delegated into ICBs and will be run, as it were, by ICBs. But because of the fragmentation, we're kind of consolidating it in one space because there's some specialist skills.
Thanks, Matt. And you're saying, obviously, one of the things that you're having to do is take stock of those people wishing to take voluntary redundancies. So I suppose one of the questions that's posed to me is, how do you kind of balance that out? And I'm sure that there's a very well-rehearsed plan in respect of that. But the questions that I'm asking on a day-to-day delivery, who are those people within the ICB that people within our system are going to be working with effectively to deliver what we need to carry on delivering? So how do you manage kind of potential deficits in some of the areas?
Yeah, I mean, at the risk of loading more onto them, the executive team are obviously all appointed. So you've got an ultimate point of escalation. And, we recognise that there's going to be a degree of that. What we also have, and I've got a couple of people in this position, very experienced people who are towards the end of their career, who recognise that, we recognise they've got a great skill set and we'll manage that fuzzy period I said. So there's a couple of people who's we're just at the, I can't say more on it because we haven't actually approved the voluntary redundancy. It hasn't been finally confirmed in its main part. But there'll certainly be an element of that as we run through. We're really, really clear we have to maintain the service over the period. But yes, it's a risk, and we've made the board aware of that risk.
It's not, it's just obviously the offer of the transition arrangement and working with partner organisations, certainly from a county council perspective. You need to look at kind of changes in what people are doing and that kind of induction and getting up to speed. That's certainly an offer that would be provided from our point of view, and I'm sure that colleagues around from community and voluntary sector districts and boroughs and others would indicate the same.
That's a great offer, Tracy. And one of the comments we had in one of our many consultation events was, I'm in Northampton. I'm going to have to work across Leicestershire and Northampton. How do I get up to speed with what's going on in Leicestershire? Because I don't know it. And it's that sort of context would be very, very useful. Thank you. We'll take you up on that.
Thanks. I suppose it wasn't really a question for Matt, more of a question for Health and Wellbeing Board. Probably for you, Chair, really. It feels like, going back to Ed's point, that there's an awful lot happening in terms of strategic commissioning, neighbourhood planning, lots of things that we're all trying to get our heads around, but I don't feel at the moment like we've really coordinated that. And I wondered whether it's perhaps time for another, what do we call them, health and wellbeing partnership meeting thing?
Is it a development session?
Yes, development session with health and wellbeing partners. It just feels like there's so much happening, and what I worry about is that we might go off in a slightly different direction, or as Mike said, we could be halfway down the road on something. And anyway, just a question. Thanks.
Yeah, we're in the process of actually discussing a development session, systems leadership, partnership working. Yeah, it's under development at the moment. Did you want me to hand it?
I was going to say, me and Abby had a conversation with Debbie, led the facilitating the previous sessions. That was last Friday. So you remind reader.
Oh yeah, forgot about that. Now I'm starting. I think that collaboration with UHL and LPT is also very important because, they've got different paperwork, they've got different systems, and most community services are going to be dealing with a GP or an ACP. They're not really going to be engaging with UHL clinicians. So having, even things like one prescription, using the same prescription chart, just makes it a lot easier for community teams, especially if we're going to be having neighbourhood models of care. So I think that's a really good point. Thank you. And yes.
Hi, Matt. It was just to sort of reiterate what Tracy was saying. Yeah, we're more than happy. I had already said to Toby and Annie when I met with them about if there's anything we can do to help colleagues in Northamptonshire understand the voluntary sector across Leicester and Leicestershire, just let us know. But I suppose it's also a wider offer, I suppose, in picking up what you're saying, Jean, which is, again, with going down to sort of neighbourhood models of care and what we're going to be looking at and all the changes. I'm more than happy to do anything session-wise or anything like that about explaining what the voluntary sector are currently able to do, are doing, and where there are the potential opportunities that actually might help with what we're trying to achieve across the place.
Thank you very much. So I will propose that the board notes the contents of the report and the 5-year strategic commissioning strategy. And can I have a seconder? Thank you. All those in favour? Yep. Excellent. Right. Well, our final report is the terms of reference of the board, which is on pages 245 to 255. Our very own Ewan Walters will be presenting the report.
Thank you. So there are two main reasons why we've brought this report today. The first one is because we need to review the board membership, and then the second one is because of the proposed changes to the operational delivery groups which sit underneath the board. With regards to the terms of membership, this mainly follows on from what Matt has just presented. Unfortunately, the ICB are no longer able to send a clinical representative to each member of each board meeting, though they have offered to send a clinical representative to specific agenda items. So we're going to have to remove the clinical rep from the board membership. And also, it's proposed that we reduce the ICB non-clinical members down from 3 to 2, mainly because of ICB availability, etc., just to make it easier and help with choracy, etc. There's one other proposed to the membership, which is I've not actually set out in the report, but it's something which has come up since I published the papers. You'll be aware that in the membership, it refers to the Chief Executive of Leicestershire County Council. We now have a new Chief Executive, Jane Moore. Jane Moore is quite happy that we've got the 3 directors from LCC on the board. The board's in their capable hands, so she's happy not to be on the board membership. So it's proposed to remove the Chief Executive of Leicestershire County Council from the membership, if everybody's happy with that. There's a few other membership changes proposed, which I've set out. They're all in the appendix to the report, so I won't go through those in detail. And then just to mention that the other main changes to the terms of reference relate to the operational delivery groups which sit underneath the board. It's proposed to add the full list of groups to the terms of reference, just so everybody's clear what there is and improve awareness. There's the one big change which Sean went through earlier to the Children and Family Partnership. So you've already approved that change, so we'll just change that to the terms of reference. And then the other proposal is a new operational delivery group called the County Place-Based Team, which my colleagues Mike and Abby will fill you in if you wish, but that's everything from me. Thank you.
Yeah, so if I go first, Abby, correct me if I'm wrong. So we've had groups that have been meeting informally. So Lisa, Abby, Kerry, Rachel, Gia and others have been meeting, and Tracy have been meeting informally as a kind of place-based coordination group, if you like. And then alongside that, we've also got David Williams from LPT with his kind of West Leicestershire neighbourhood working pilot hat on, has established a working group as well. And given so much of what me and Ed observed yesterday from the event that was about community health and wellbeing plans and neighbourhood health team development, and the conversations that we've had here around neighbourhood health models, the UHL, clinical strategy, and the rest of it, it feels to me like we could do with recognising that a group, if you like, is taking forward place-based working, encompassing, steering, all that stuff that, if you like, has been the business of today's agenda. We could just let that happen organically and let people meet. I think there would be benefit of formally recognising that as a working group of the Health and Wellbeing Board, partly so we can ask for updates and it formalises, I guess, the input that a number of people have had around here anyway. And it would just give a little bit more formality, I suppose, to make certain that when we're thinking about the links between system, place and neighbourhood and the role that this group, I think, needs to have to glue it all together, to use a phrase that was used earlier on, but it recognises the role of the Health and Wellbeing Board as that kind of health place leadership group is all I can put it. So I don't think it's necessarily a radically new departure, but it almost might end up taking a couple of groups and recognising one and folding two groups into one, but then just basically it's making certain we see it as being an essential part of the work of the Health and Wellbeing Board. In itself, it wouldn't be like we've got these other four groups, wouldn't be a fifth pillar. I very much see this as being the one that needs to kind of take forward place-based working and working across children's and staying healthy and all the rest of it. So so I think that's kind of my brief really. I just want to see something in place that recognises neighbourhood health and the join up between system, place and neighbourhood is pretty essential to the work of this board. Abby, do you want to say anything else?
I think you've covered everything there, but it would be great to soundboard some of the agenda items that are coming to Health and Wellbeing Board and actually talk about the content of future development sessions, if you alluded to, Jean, today. So using that space across that system.
Looking at Lisa, so just in, shout out from there. I mean, potentially, I think just to be clear, when I said 2 into 1, there's a David Williams led neighbourhood place group. And I think I know it's more operational detail, which meets tomorrow, but if that was to take on the kind of joint health and wellbeing strategy and health and wellbeing board support bit within that agenda, I think that's the group I would see then being the formal working group of this committee.
Any further questions? Oh, yes, Ed Coverley, go ahead.
Thank you, Chair. Yeah, very supportive of the approach. I think it makes sense to try and draw some of these threads together. So it speaks very much to the point I was making earlier on. A very small point, and it's not an issue, but just in the terms of reference, it also refers to a broad range of partners, not limited to, it doesn't reference district councils. I think it would be useful to have a direct reference there to districts, just so that that perspective, particularly at neighbourhood level, is feeding into that process. So I'd welcome that addition if the board is supportive of it. Thank you, Chair. I'm not precious, Chair, so I'm happy to keep the governance light. If it can be noted in the minutes, then I'd welcome that, and then I'm more than confident that colleagues will support.
I suppose it's the move from just saying, of course you're included, because you mentioned under organisations, to just going, actually, no, you're a pretty key player in this bit, so it'd be good to recognise it explicitly.
Thank
you. Okay. Thank you very much. Well, I will propose that the revised terms of reference for the Health and Wellbeing Board be approved, including the addition of 2 new operational delivery groups and the removal of the Chief Executive from the membership. Can I have a seconder, please? Those in favour? Yeah, excellent. Yep. Item 14. I think it might be on social media later. Agenda item 14 is the date of the next meeting, which is Monday, the 15th of June at 2 p.m. There are no urgent items, so I'll draw the meeting to a close. Thank you very much.